Yeah, thanks. My pleasure. Yeah, I put on the tie when I can to groups that I don't talk with very often. So it's a good opportunity. Here, let me share my screen and jump in.
Great.
All right, so yeah, this is all about the Delta variant now, essentially. You can see that in much of the world, there's a lot of activity right now in terms of cases and transmission. We have been seeing a seasonal pattern for COVID in general. So it's August. You'd expect to see it mostly in the southern hemisphere. The fact that we're seeing a lot in the northern hemisphere is it's all Delta, and it's a little bit disconcerting, but this is what we're seeing. In the United States, so the two axes here, the blue and the red line are the cases that we're looking at. So you see this last surge that we're in right now in August. The yellow is the percentage of emergency room visits that are COVID related. And you see that that's rising, and we're not quite at the levels that we were peak back in December, January, but we're in the direction to get there, even though it's August. So we're not in a good direction right now. When you look at variation across the country, so here we're looking at Florida, and you can see that Florida has already greatly exceeded where they were in December, January, and are still rising rapidly. And so when we look at this a little bit closer, you can see that there is regional variation that's dramatic here. It's interesting to compare the current surge, which is a summer surge, to the summer surge that we had last year. So obviously very different variants, but there's this ongoing question: is the surge now mostly due to the unvaccinated, and that's definitely a big portion of it, or is it also due to these behavioral differences that we see in the summer, where the young are going out and going to the bars and being more active? And I think it's actually a little bit of both. We're mostly hearing about the vaccination story, but there is also the behavior story. The key thing here that I want to get, there's two key things here. One is the regional variation. So blue is the South. And so we're seeing that consistently in the summer now, we're seeing that the South is a lot higher. Then next is the West, then Midwest, and then the Northeast. You see that they're all rising, again, proportionally roughly the same. And that even within the South, some states are doing particularly poorly. Here's Florida. Just because, so the story has been, why is it so bad in the South? The story has been that that in the South, the summer there is almost like the winter in the Northeast and other regions, because it gets so unbearably hot and humid down there in Florida and other places in the South that people spend more time indoors in the air conditioning and whatnot. And that's thought to contribute to some of the spread there. However, you would think based on that story that you wouldn't see these surges again in the fall and winter. And we do see this the fall and winter. So it doesn't seem like the summer surge protects from the fall and winter surge that has been coming. The next thing is when you look across different states, I guess this is the same point. You said there's a few states that I pulled out here: Alabama, Florida, Georgia, Louisiana, Texas. You can see that some are increasing at different rates, and that they had the summer surge last year, but they also had the fall and winter surge. So just because it's summer doesn't mean that it's going to be ending there. Louisiana is interesting. Look at that's the orange line where it was rising rapidly, but then it's sort of like plateaued, it's decreasing a little bit. So let me just dive into that a little bit just so you can see what's going on there. The caseload has been going down. It's unclear whether it's primarily testing constraints or behavioral changes or something else that's driving it. And so when you dig into this a little bit further, you do see that the emergency room visits are still spiking. They're still quite high. They have not plateaued yet. And so it could be that there's something with testing going on. It could be real in terms of the plateau and the decrease. And I'll get into that in a second when we look at UK and some of these other countries. But first, more back at the United States, looking at the regional variation, you see very clearly at the county level that there's some counties that are getting hit much harder than others, even within states. Some states seem to be doing well, but they might have some counties that are doing really poorly, and vice versa. Here's the big issue. Here's what it comes down to. If we run out of hospital beds, then it causes all sorts of cascading problems. So people who might not have COVID at all, but got into car accidents, have heart attacks, have just regular reasons for going to the hospital, if there's no more beds, then that is a real big problem. And so you end up with a lot more morbidity, a lot more mortality that's unnecessary simply because people can't go to the hospital because there's no beds. And we are seeing in some hospitals in the country already that they have run out of beds. I haven't been tracking it closely in terms of what that rate is. On this map here, we're looking at the counties that have the highest hospitalization rates. Obviously, some hospitals have more capacity than others, so even if they have higher rates, it's not necessarily a bad thing. There are some hospitals where we've hit this though, and this is the key worry about hitting that level in different places. When it comes to vaccination, so clearly again, wide vaccination rate across the states. The big picture here in terms of the over age 65, approximately 80% have been fully vaccinated. Around 90% have gotten at least one dose. The second dose does make an enormous difference, but a single dose is better than nothing. So it's still some stimulation to the immune memory. Here I wanted to contrast these two things. I was trying to just do a back of the envelope estimate of what percentage of the population still has no immune memory at all. So they have not previously been infected and not previously been vaccinated. So on average, Institute for Health Measurement and Evaluation is estimating that around 40% of the US population has previously been infected at some point. The other thing is the longer ago a person was infected, the less helpful it is for a future infection. So we can get into that a little later if we want. But anyway, just at a high crude level, 40%, there is wide variation across the states. There's also wide variation in terms of the vaccination rates. When you put those two things together, again, I did not do this analysis at the state level, just a crude national level. So basically, if we assume 40% have been infected, then what this breaks down to is approximately 5%, 5 to 6% of people over the age of 65 have no prior immune experience. They've either not been infected or have no vaccines at all, not even a single dose, 5%. Among people over the age of 18, it's 17%, 17 to 18. Over the age of 12, 18 to 19, and roughly 25% in the total population. But most of these are kids, so it's going to be a little bit different. But what this means is that we're nearing the end, from my perspective, in terms of what we're looking at here. And the reason I'm saying this is, let me drop down to UK real quickly. So the United Kingdom, here's what it looked like here. The fall-winter surge that they were having, this was primarily due to the Alpha variant. And then this was that they quickly went under lockdown. And so the levels leveled off very fast. Then they started going back up again because of the Delta variant. While they were continuing to have these lockdowns, these mandates and constraints, around July 19th, just happened to coincide with when this flipped. Around July 19th is when UK reopened, but the numbers were falling similarly. And there was a lot of uncertainty. Why were these numbers falling? You see that they were falling. It started to actually rise again a little bit, but it's interesting that you see this very remarkable drop. Similarly, when you look at, or not similarly, but so first pay attention to these curves. You see how high it is here, and then how high this surge was in the summer. Now, when we look at hospitalizations, you see that the hospitalizations have been far lower, and it's also peaked around the same time. And so the question is, well, why are these numbers so lower? The clear explanation for why the hospitalizations have gone down are the vaccinations. They're very effective, they work. But interestingly, a lot of people don't realize this fact right here. Around 94% of the adult population in England and the UK have been infected or vaccinated previously. So we're only talking about 6% of the population that have of the entire adult population that have no previous exposure of any kind to the virus. And when you start seeing this, that's when you start seeing these numbers go down. And really at that point, that's when it sort of switches from being an epidemic and a global pandemic to sort of just being this endemic thing where you have these infections that occur, but it becomes increasingly just asymptomatic or colds for the vast majority of people. That's it with UK. So when I come back to the United States, these numbers are actually, I think, it's bad. The surge is still going to continue for a while, but I think that it's going to, that the end is in sight here for a couple of reasons. One thing can just jump to now that I've talked about that real quickly is this where is this that I was looking, is this. So basically what we're looking at here is a combination of a lot of the forecasts that have been done. I don't think I see IHME here, but this is basically an ensemble forecast of a lot of different projections. The solid black line is the average across the models. The gray is the range across the models. Most of the models are assuming that we'll have a peak for this surge at the national level. It'll vary by state that we're already seeing dramatically, but at the national level by around early to mid-October. However, when you look at these dots, this is the actuals versus the forecast. You see that the actuals have already vastly increased relative to any of these forecasts that are out there. And it's just because the Delta variant is so contagious. I haven't mentioned this earlier. I should have said this at the beginning, but basically the Delta variant is 2 to 3 times as contagious as what we were experiencing last fall and winter, based on the common variants. It's roughly now closer to 2 times as contagious. We do know that there's a seasonal component to how contagious the virus is, and that we tend to see the COVID viruses increase in how contagious they are by around 30% when you move from summer into fall, winter. And so that means we're probably going to be getting up to 2.5 or more times as contagious in fall and winter. We do know that the viral load is orders of magnitude larger. So 3 orders of magnitude, that's 1,000 times more virus that's produced per infection on average per patient. And so this has 2 consequences. One, there's just so much more virus that's produced that it's so much more easy to infect other people. And that's why it's so much more contagious than anything else we've seen out there with COVID, any other variant. It's approaching some of the other viruses out there, like measles and chickenpox, some of these really, really contagious viruses. It's getting up to those levels. And 2, that also has an impact on severity. We're unclear what the impact is. There's been this uncertainty. Are we seeing hospitalizations at the same rate that you would expect, and we're just rolling the dice more? So that the probability per dice roll is the same, and we just have a lot more frequent rolls of the dice, and that's why we're seeing all these hospitalizations. Or is there actually more severity among people who get sick because there are higher viral loads and it's harder for people to respond? And we do think it's a little bit of both. We don't know the exact quantification. With the UK variant that hit, so that was B117 that hit months before the Delta variant, we assume that it was around a 50% increase in severity versus not. And that was largely associated with the viral load. And so we don't know for sure yet. We do know vaccinations are really having a big impact, but the viral load is this other thing that we need to worry about. There are a few other things I can talk about here, and then otherwise I can open for questions. But let me just go through some of these other slides. How are the vaccines holding up? So basically the 2 sources of evidence that we have here, originally, the UK showed an efficacy against infection. Let me differentiate here. So basically the vaccines, we're asking for them to do a lot. We're asking them to prevent actually getting infected. So that's one thing, so not getting infected. The second is that we're asking it to so that we don't have severe symptoms or hospitalizations. And so that's, and death ultimately. So that's the second thing we're asking. We don't want these hospitalizations. And then the third thing is we're asking it to prevent transmission and not infect people around us, to sort of contribute to this concept of herd immunity. That's a lot to ask for vaccines, and we don't usually ask that of vaccines. Usually for vaccinations, we only ask one thing, and that's to keep people safe. Essentially what that means is keep them out of the hospital, keep them from having severe disease and dying. In this case, we were really enthusiastic, way more than anyone was expecting, that the mRNA vaccines in particular have not only been keeping people out of the hospital, but they've also actually been preventing infection, because this initial dose of antibodies and immune response is so high that it's actually good at preventing infections. And in addition, has also been, because of that, it's also been good at preventing transmission. And so, but the numbers now quantifying it come from a few different sources. When we look specifically against infection, what we're looking at here is originally the United Kingdom, which had really good data, and they have the National Health System, they can track this really well. Originally, it identified that the vaccines provided 88% efficacy against infection, which was strong. Now it looks like from Delta, it's closer to 50%, which is still great. The idea that 50% are not even infected. This is not hospitalization. This is, and that's at the end of the day, really what we care about. If someone's infected and is asymptomatic or has minor cold-like symptoms, it's really not a big deal. The only problem here is not only the hospitalizations and death, but then infecting other people. Because now what we have are a lot of vaccinated people who are silent but deadly and going around and potentially infecting people around them. And that's why we have the new mask mandates and stuff. But anyway, so this is coming from the UK. We still have a 60% reduction in symptomatic disease. And in terms of reduction against hospitalization, it's still holding up essentially as good as it was before. We're still only around 5%, so 1 in 20 of people who previously would have been hospitalized are now being hospitalized after the vaccine. Israel, the efficacy is not quite as strong. Now they're down to around 39% in risk of or the efficacy against infection versus the 49% that we saw in UK. Part of it might be due to data issues. Part of it, more likely, simply might be because in the UK, they wanted to get as many shots into arms as they could at the beginning. So with the 2-dose regimen, they gave 1 shot and then waited 12 weeks on average there before a person got a second shot. Whereas in Israel and many other countries, including the United States, we had the first shot, then we waited 3 to 4 weeks to get the second shot. And we do know that the longer you wait in between the first and the second shot, the more the efficacy is. The longer the distance between that, the bigger the efficacy. And so that might be some of what we're seeing. However, the biggest takeaway here is that there's still an 8-fold reduction in disease incidence, 25-fold reduction in hospitalization incidence, and 25-fold reduction in death. So that's huge. Across the states, you see that the states that have not vaccinated very well are strongly the ones that are now have cases and hospitalization versus the ones that have vaccinated more. Again, there might be some compounding here that I discussed a little bit earlier because of the behavioral changes in the South and other things that we saw from last summer, where we also saw more hospitalizations and cases there, and that was before there were any vaccinations. So both stories, I think, are going on. The one thing to point out here is that vaccines, when we use vaccines, the whole purpose of how they work is we assume that there's an initial infection, or with the case of vaccines, an initial dose of the vaccine, then the antibody levels decrease. We have this memory in our immune system, and then at some later point when there's a repeat infection, then we more rapidly have this complicated immune response that happens. And in fact, we're seeing this in real life. And there's a Singapore study published recently that shows that when you compare the green vaccinated people versus the red unvaccinated people, the green vaccinated people were able to clear the virus within around 6 days is when they were starting to see very, very strong efficacy. Whereas the people who were first infected for the first time, this red, typically had higher viral loads for much longer periods of time. So the vaccines are very effective, or rather effective, and they're doing exactly what we had anticipated. Here's another really great punctuates what I'm saying here. This is the percentage of hospitalizations among vaccinated, or hospitalizations for COVID among vaccinated versus unvaccinated. This is by the Kaiser Foundation. And so they've been doing these great surveys. And what you're seeing is that from like 0.1% to like 9 to 5% of all the COVID hospitalizations are among vaccinated. The vast, vast, vast majority are among the unvaccinated. Let me jump to the next thing. I see we're running out of time, but a few other things. People have this question, well, they were naturally infected. Why should they get vaccinated if they were previously infected? What we find with the previous variants, so before Delta, is that typically people who were naturally infected and not vaccinated were around twice as likely to become reinfected as people who are vaccinated. Now with Delta, because it is so contagious and the viral load is so high, that we're looking that it's 4 to 6 times. So people who are naturally infected are probably around 4 to 6 times as likely to be reinfected with Delta as people who are vaccinated. And this is data that's coming out of the National Health System of United Kingdom from Public Health England report. I talked about UK. Let me just jump. There's a few other things that you might find interesting, so I'll just talk about them. Some people still are getting long COVID after they're vaccinated. So this is something we're not going to have to keep an eye on. This was from a small Israel study. So this is still something we're keeping an eye on. This Provincetown you might have heard about, this is sort of what triggered the CDC to, this outbreak there is what triggered the CDC to change their guidance on masks. Essentially, the evidence there that was supporting that is when they looked at the viral loads among unvaccinated infected people versus the viral loads in infected vaccinated people, they found that they were essentially the same. It was essentially this one graph that led the CDC to make this change, that if the viral loads are the same, they assume that how contagious the people are is roughly the same. It's not necessarily clear to me that that is the case. We do know that people who have strong antibody defenses might still carry a viral load after the infection, but might not actually be contagious after a while. So, but generally, this was a very good opinion. Right now, virtually all states should be masking up now, just because the risk is so high here. And so that's where we are. In terms of the risk, there's just a couple other things, and then I can go through. First, I'll just talk about kids, and then I'll be talking about, are there other variants coming? We've been talking about epsilon and lambda and gamma and alpha and delta. And so what's this? What does the future hold for that? But first, I'll just talk about kids real quickly. So what we're looking at here is the risk. This is the log scale. So on average, people who are 90 years old had a little bit higher than a 1% risk of dying if they got COVID. The vaccinations then lower that risk to the same risk as someone who is roughly 60 years old or so. And so someone who's 80 had roughly a 1% risk of dying. If they were vaccinated, it lowers it to around age 50. And so you see the log scale here. You see that people who are younger and unvaccinated tend to have a much, much lower risk in general of either severe morbidity or mortality. So we have to keep this in mind. However, because the virus is so contagious, you're just rolling the dice so much more that so many more people are going to be getting sick, hospitalized. And again, because the viral load is higher, you do see a little bit more severity. But again, just extrapolating this down to kids, say under the age of 18, you see that the risk is very low. What does this look like at the national level? I know that there's a lot going on this page. Let me just draw your attention to a couple of things. First, among kids aged 0 to 17, proportionally, you can see that the rate of hospitalization is going up very fast relative to where we were throughout the whole rest of the epidemic in the United States. So it hasn't peaked. It's going to continue to go up for a while because a lot of states are still struggling with this. And we're just seeing the beginning of this surge in much of the country. However, so this kids are sort of this gold color. When you look here across all age groups, in fact, I can make this a little bit bigger, across all age groups, you see that kids still have a very, very small risk relative to the other age groups. And so this is something that is important to keep in mind. The vaccines are working. So when you look at the oldest people who are the age 70 and over, I think is the red, 70 plus, you see that they're much, much reduced risk of hospitalization, but the vaccines are not an immune shield. And we still saw that there are quite a lot of people who are over the age of 65 who are unvaccinated. It's not as much as it was before, but we're still talking, I think, roughly 5% order of magnitude. All right, the other thing is, if you look at this chart again, this is at the national level. If you sort of go into region 4, which is the southeast, then if you compare what it looks like at the national level, here's where we are in the south. The rate of hospitalizations, and this is where most of it's occurring right now, is very rapidly exceeding any other point in the epidemic so far. So the big question is, as kids are starting to go back to school, what does this mean? Previously, there were 3 strong empirical reasons for why kids should go back to school in the fall. The first was that they tended to be much less contagious than adults. If they got sick, they couldn't infect anyone else around them. The second was that if they did get sick, the severity was orders of magnitude less. And so that was an important reason that it's almost didn't matter as much. And then the third reason was that if there are important reasons for kids to have in-person learning. And so those 3 reasons were the reasons why all the kids are going back now. There's now this uncertainty. If kids, if the Delta variant is now 2 and perhaps as much as 3 times as contagious in the next month or two, then that changes the math a little bit, because now kids, instead of being much less contagious, now kids, whereas before if one kid on average infected less than one other kid, now if one kid on average infects 2 or 3 other kids around them, this could cause a problem. Then the other thing in terms of severity, if the viral load is increasing, you see this increase in hospitalizations, that could be a problem that we're talking about. Basically, I'll jump to this slide here. Since this time last year, there were 45,000 kids have been hospitalized with COVID-19. Roughly 400 kids under 18 have died from COVID-19 before the Delta variant. Before Delta, the number of COVID-19 deaths among children was roughly, but a little bit more than twice the number of pediatric flu deaths reported by the CDC between 2019 and 2020, which was one of the worst flu seasons since 2010. So now with the Delta, particularly when you look at the South that we were just looking at, this could very quickly rise far higher than that hospitalization rate that we saw for flu. So we might not be talking about 2 times as much. We might easily be getting into territory where we're talking about 5 times as much, perhaps 10 times as much. I don't know, people, it's a little bit early. And so we as epidemiologists, we like to use evidence to predict these things. And so right now, you haven't heard a lot of talk about reclosing the schools or that kind of stuff. And I think that we should try as hard as we can to keep the schools open. But certainly we should be masking as much as possible in these schools and be doing a lot of things, because this is becoming a more serious disease for kids. Still, again, order of magnitude compared to other ages, again, it's not anywhere near as serious as for these other ages. However, kids are kids, and we don't want kids to get in this kind of trouble that we're talking about. All right, I'll just end it. To one more, unless you have a specific question about this, I was going to talk about variants and then open it back up. But if you have a specific question, I can jump to you.
You're on a roll, Glenn. By the way, we do this every week, and you can come every week. So keep going.
I don't know that I have the time every week, but I can.
I know.
So here's a key point that you might not have heard in the news as much. Variants are becoming less diverse over time. So basically, the Alpha variant was driving out all the other variants. A lot of people don't realize, I think I might have mentioned this in previous weeks when I've talked with you all, is that the original Wuhan variant no longer exists in the world. It was outcompeted by its descendant variants, which were more contagious. And so because of that, the Wuhan variant did not have any host bodies that it could infect, because it was outcompeted. And so the Wuhan variant has gotten extinct. Other variants have also gone extinct. And what we're seeing is that variants in general are becoming less diverse. Delta is overwhelming everything. And in fact, you might have heard of some of these other specific variants out there, the Gamma variant and Lambda. The reason that these have come out is because there was some theorizing and some evidence that they might be able to break through the immune barrier of the vaccines, the vaccine barrier to a greater extent. However, when you look at the countries in which they're existing, in purple is Lambda, and in this light green is the Gamma. Let's start with light green. In Peru, you see that there was a little bit of light green here. The light green grew over time. In Chile, it grew from, 30%, or rather 38%, it grew to 73%. So this Gamma variant was very scary. However, when you compare it to a head-to-head comparison of Lambda, Lambda was 91% in Peru, and Gamma outcompeted it. And so Lambda has dropped from 91 to 81% by June. So this is April to June. Similarly, in Chile, where you had the Gamma, the Gamma was way more contagious. And so Lambda, which was 40%, has now dropped to 24% by June 28th. So clearly Gamma was outcompeting Lambda, and anywhere in the world where you were seeing Lambda and Gamma, Gamma was pushing the Lambda out and making the Lambda go away. Now, the question is, how does Gamma compare to Delta? And so when you do a head-to-head comparison here's, I put Brazil in there just as a side thing, because Brazil, I claim that Brazil hasn't gotten Lambda because it was protected almost in a sense, because all of the variants were Gamma and Delta and stuff that we've been looking at. But here's Brazil, here's Gamma. It was in June, was at 95% Gamma, and a very small percent, what is this, 5% less of Delta. By August, Delta in Brazil has risen to 19%, and Gamma has dropped to 75%. Similarly, in Peru, Peru had, oh no, you can't see Peru. The problem is reporting that a lot of these countries are not sequencing their variants very often. So there's not great data that we see. So I just try to pull the data that I can. But here, when you look at Chile, Chile had very, very little Delta back in June, but then it has risen to 7.5%, which doesn't sound like a lot. But when you look at the rate of growth, this is tremendous growth. And when you look at where they were at 73% Gamma here, that's dropped to 64%. And they were at 24% Lambda, that's dropped to 20%. And so Delta, when you look anywhere around the world, without exception, Delta is outcompeting everything. And so this is potentially good news. We've talked in some places about peak fitness. It could be, and there's a legitimate worry why this might not be, the concept of peak fitness might not be a legitimate thing to even talk about. I know Fauci and other people have still worried that because people aren't getting vaccinated enough and whatnot, that we could have breakouts, that we could have other variants that form. My point of view is that because Delta is spreading so crazy fast everywhere, it's forming like a bottleneck. And so that means any escape in the future may probably have to come out of Delta and descend from Delta, as opposed to the great diversity of other variants that were out there. So I think that this is probably a good thing. We really do need to get the rest of the world vaccinated as much as possible. We do need to get us in the United States vaccinated as much as possible. But even without the vaccinations, Delta is going to go and just infect everyone within the next 6 to 12 months or some period of time. And there's not going to be any escape from it at this point. So so that's not, for whether it's a good thing or a bad thing, it means that the global pandemic is likely to be, that the end is in sight, I think. It's going to become endemic, lots of asymptomatic spread, similar to, I think I put here as just as a backup slide, what does the cold and flu look like? So there's currently 4 low pathogenic coronaviruses that just have code names, 229E, NL63, HKU1, OC43. They just cause the common cold every year. And typically, so it's cold or asymptomatic. We're probably just going to evolve into something like this, where once people start having an immune memory and are vaccinated or just or have been previously infected, at some point, there'll be some people with more severe illnesses, but generally across the board, a lot of people will be infected, but it'll just be more like a cold and flu. That's what I'm imagining. There is still some debate out there in terms of what that will look like. But certainly we're seeing, when you look at UK, when you look at some of these other places, vaccines are working. And so that's it. All right, that's all I have here, unless you have specific questions.
That's not good enough, Glenn. We want more.
I mean, I do have lots of other slides, but that's more.
I see that. And, do I see that we have access to this?
I sent it as a PDF. Yeah,
I appreciate it. Thank you.
Inessa put it in the chat. So if you need access, just go to the chat.
So look, I mean, can I? This is my own, because I got a 4-year-old, so now 5, 12 and 16. For that 5 to 11-year-old range, that is, sort of, at least in our community, there have been carriers to some extent, and they have their own issues. And it sounds like, is there I don't know, conventional wisdom on whether their vaccinations would start for that age category?
Yeah, so that's a really interesting question. So yeah, I did not have a slide on that, but I can voice track it. So basically, when we're talking about expanding vaccinations to kids who are under the age of 12, so there's a couple of different things here. First, when we're talking about expanding vaccinations to kids under the age of 12, it's always balancing the risk of severe disease from not vaccinating versus the risk of the vaccine itself among these kids. The issue here is that among kids under the age of 12, the risk of severe disease is so low that the balance changes. Like, you could have an extremely safe vaccine, but if it's even the tiny bit risky at all, it might throw out that ratio because there's so few people getting sick or hospitalized. And so that's the tricky thing here, and that's what they're looking at, and that's why they're being extra precautious. I think Pfizer is ahead of Moderna in terms of looking at this vaccination in kids under the age of 12. It has been approved for kids over the age of 12, and definitely the ratio there, the value of the vaccine is tremendously higher for the 12 to 15-year-old group versus not getting the vaccine, and because the hospitalization, particularly around the age of puberty, the body changes, and it does put kids a little bit more risk at that point. But among kids under, I think the last I heard is we're expecting a readout probably within the next month or so, maybe a little bit longer for kids. And then it'll probably take the FDA around 3 to 4 weeks to evaluate that data and launch it. But yeah, it's a tricky thing. I don't know if that answered your question or if you have anything in particular.
Yeah, we expect 10 slides on that next time, Glenn. But no, good. Thank you again. I'll open it up to other questions.
Hey, Glenn, just a follow-up question on that. I know there was a report that Louisiana, I think their children's hospital was at max, and I'm not sure if most of those cases are all the Delta, but is it safe to kind of assume that Delta is really targeting more of the younger population?
So Delta is targeting everyone. The thing is, so this, I heard in Australia, this is where the quote first came out of, but now people are just using it regularly. So back in December, January, the variants that were circulating, it really, on average, required around 15 to 30 minutes of exposure to get infected. Wow. Now with the Delta variant, because the viral load is so high with each breath, it only takes 15 to 30 seconds to get infected. And so it's not just the case that kids are more likely to get Delta, it's that everyone is getting Delta. We're seeing it more in kids because the older populations tend to be vaccinated more. And so that's the reason. And so on average, if we're looking here, let's pull it, this one. So if this is the latest in the United States, so roughly 97% of all the variants in the United States now are Delta, then that means if someone gets infected, then on average, they have a 97% chance that that infection is a Delta variant. And so it's just, and this is going to overwhelm. It's going to push everything out. We're seeing in a lot of other countries. I didn't pull it out in this slide, but you can see in this one, it's wherever Delta exists, it's pushing out all the other variants. Now, Delta is still evolving. So there's Delta Plus. There's now we're using different labels that you might start to hear over time. One is AY1, AY2, AY3. But I see that as mostly fine tuning so far. And we might see some differences arise. But basically, it's Delta. The story is Delta now for everyone.
Glenn, thank you very much for the presentation. I second Mark's motion that you come back.
Yeah, my pleasure. I'm as an epidemiologist. This is the glory days. I love this.
I've got two questions. In terms of the mutation. What are the primary areas, characteristics of those mutations? I'm understanding that is the really the viral load and the contagion aspect of the virus. The other question is there a cap as to what's the end game in the mutation? I mean, it can only mutate so much. Whereas you had mentioned that the Delta virus now represents pretty much a bottleneck for the others, and it has become the dominant. So those are my two questions.
Yeah. I'll answer your second question first. So there is a worry. So when you look back at the diversity of other variants, they were evolving in all different ways. And some of them, for instance, Lambda, the reason that had come up in the news more, was more effective at escaping our vaccine protection. The problem is there is a theoretical possibility that Delta, even though it's unrelated to Lambda, I mean, they're all COVID viruses, SARS-CoV-2, but even though it's a different pathway, they could still evolve back to what Lambda was with these additional mutations and become more vaccine resistant over time. And that is a legitimate worry. The thing is that as people, so our persistent effect of our immunoprotection, it's strongest the more recent the infection. So if we were recently infected and if we were recently received the vaccines. So within the first 90 days, we have the strongest protection. So it's 90 days from the second dose or 2 weeks after the second dose of the vaccine or 90 days since the infection. And it decreases over time. So because Delta is hitting so many places all at once, presumably that this idea of herd immunity is a little bit worrisome because we know that there's no real herd immunity the way that it was conveyed months ago. But you do have this protection, and that's why we see this drop from the peak. In terms of why, specifically what's going on a physiological level of why Delta is so much more contagious, I think generally it is the viral load that's making it more contagious. I think there still is uncertainty specifically what specific mutations are responsible and sort of how they're having an effect. We do know that there are some mutations on the spike protein that can make it so the virus can attach more strongly to the cell. And so that might be something that's going on. There could be other things going on with different portions of the virus. But I think that there is still this uncertainty. It's more contagious than we would have expected based on our understanding of the mutations alone.
Thank you, Glenn.
Absolutely.
Hey, Glenn, I have a quick question for you. Business leaders have been struggling with how to safely get their people back to work, and their plans are evolving. What advice would you give companies, particularly those whose people have to commute to get into the city like New York, about getting people back to the office?
So absolutely, as long as transmission is still high. Oh, I didn't put a picture of the transmission. Basically, when you put a picture of the state level of transmission from the CDC, it's basically the whole country that's orange, bright orange or bright red. So that means basically everywhere around the country, people should be wearing masks full time if they're back in the office. And a lot of people don't like wearing these masks in the office, and particularly commuting. The risk is high. In New York City, if you're talking about commuting on a subway, we're talking about risks. So as bad as it is in terms of how contagious the virus is for much of the country, it's even worse if you're trapped on a subway with other people. It can easily be that the R naught, so the reproductive value in terms of the virus, could easily exceed 12 or 15 on a New York City subway if someone is infected, how many other people they might be able to infect without the masks and without this other stuff. And so it could be problematic. I think that different companies, different organizations are going to decide for themselves what their comfort level is, but definitely, particularly if there are employees who are living in the same household with other people who are unvaccinated or who cannot become vaccinated because of high risk comorbidities, that could really be a problem, because when people go back into the office, even with the masks, previously with the previous variants, the masks reduced the risk of spread by around 40 to 50% if you wore a good mask and you wore it properly. Now with the Delta, because the viral load is so high, we do know that the longer the length of exposure, if you're in, say, a bar with the mask for a half an hour, that's very different than if you're in an office for 8 hours during the day. The masks lose a lot of protection, because even though the protection is there, it's just so many hours of exposure means that it just dramatically increases the risk of a person getting infected in a closed space. So, I mean, there's respiratory interventions that people can do in terms of having cross ventilation in the air in the office buildings and whatnot. But Delta is definitely changing the game here.
So would you be advising CEOs to then postpone till, and they were talking about Labor Day, now they're talking about October. Would you be recommending that if you're in major cities that they would be delaying till the new year, or how would you advise the CEO?
Yeah, so I mean, for me, it's hard to look that far into the future. It should all be based on local transmission. If local transmission is low, then it's okay to go back into the office and not wear the masks per se. But if you start getting the transmission higher, then it becomes an issue. It's hard to predict exactly where we're going to be in October. Like I said, the models that are on average are predicting that we're going to be looking at early to mid-October as peaking. And so maybe if they come down, which some are saying that they will, then by December, maybe it will be okay. Some models are still suggesting, well, by December, we know that it's 30% more contagious come fall and winter. And so December won't actually be good because then we're in the regular cold and flu season and SARS-CoV-2 could be spiking again then. It's unclear. Typically, the faster it surges, the faster you burn through and the peak starts coming down again. But it's hard to predict this stuff. I know you want a clear answer. When do people go back to the office? It's hard to know right now.
No, that's actually a great answer because I think people are trying to be falsely precise and putting their employees at risk if they're not thoughtful about it. So thank you.
Sure.
Glenn, is there any data on travel within the U.S. on flights spreading of this?
I haven't been looking too closely at this question recently. I do know that the airlines have been very strong at marketing how safe they are because people are not going to be willing to fly if they don't think it's safe. So as a result, I think that there have been mandatory mask wearing. There have been, I don't know the specific policies, but I'm sure that the vaccinations and whatever are going to be required a lot more for these populations. But in terms of outbreaks, I haven't been following it as closely. And the problem again is with Delta, studies that were conducted 4 months ago are not going to be accurate per se of what's going on now or in the next couple of months because Delta is so much more contagious.
Hey, Glenn, as always, fantastic. Quick question: if you watch the charts of the cases for the U.S. and the UK, it appears as though that the U.S. tends to lag a couple of weeks, as in like 2 to 3. If you just follow the charts,
yeah,
it sounds as though that may not be a good extrapolation for where we are right now. In other words, since the UK peaked, I don't know what, about a week or 2 weeks ago, that if that pattern continued, then we could say maybe end of the month into September. But your chart there, was showing again kind of the model ensemble more into October.
Yeah, they're an early indicator. I think they were surging 2 to 3 weeks earlier, let's say. The problem is the United States is so vast. It's hard to compare the United States as a country to UK as a country. It would be a better comparison to compare UK to, say, a specific state. And the problem is that we're going to see the surges happening in different states at different times. So when you look at the average at the US aggregate, it's going to be looking like a much different curve just because we have so many different states and they all have different things going on in them. So I don't think we can use UK to say, oh, well, if their surge is going down, that means ours is going to go down. I think there's too much going on here.
One other quick one. I had seen in terms of a comment between natural immunity, from having COVID, versus the vaccine, the fact that the vaccines tend to target the spike protein specifically, whereas the natural immunity tends to be a little bit more broad-based against a variety of characteristics of the virus.
Yeah.
Do you think that that's an accurate statement, or yes, no?
Absolutely. So typically the immune system is extremely messy. And so a virus has lots of different parts. It has the spike protein. It has all these other proteins in there. The immune system doesn't know which protein is the really bad protein. So we produce antibodies to all the proteins or to many of the proteins all around the virus. And the problem is a lot of these antibodies just don't do anything. It's really the spike protein that does all the good heavy lifting here. So because the vaccines are so targeted, it has two benefits. One, it tends to be more likely to be neutralizing. And so we don't get infected and don't infect other people. But then two, it also is more resistant in some ways to the variants. When new variants come around, with new mutations, the vaccines tend to be more resistant to that. There is a theory, so based on just how the immune system works, that if someone's naturally infected, the body continues processing that for months after, and generally on its own would just sort of mutate the antibodies to respond to likely mutations that might occur in the virus. And it's just a natural way that the body tries to anticipate how the virus is going to mutate in the real world. But despite that great functionality in our immune system, the vaccines are definitely proving in the real world to be way more effective.
Glenn, I have a question of immunity boosting and whether or not you have a point of view about anti-inflammatory nutritional direction, plant-based, or any other preventive health topics such as vitamin D, C, zinc, etc.
Yeah, I don't have a strong opinion on these things. I've been looking at some of the research. It isn't very clear to me. I've seen some benefits from some of the research, some that are suggesting it's not a benefit. The vaccines are so powerful that's the big takeaway here. The other thing is that sure, eating healthy makes a big difference. A lot of people who are getting most severely sick have these comorbidities. So even when you look at kids, let me go back to wherever that slide was here. So here, I didn't talk about this slide. Roughly half of the kids who are infected, or rather hospitalized with the COVID, roughly half have no pre-existing medical condition. But that means that roughly half do have a pre-existing medical condition. And when you look at adults, it's much higher, even among the adults. And so that means if people have pre-existing medical conditions, the most important thing is not the zinc and the vitamin C and these other things. They really need to get these other symptoms and these other diseases under control. So adequately treating them, doing the health advice that doctors would typically say for these other diseases. That would be definitely the strongest thing that someone can do.
Hey Glenn, let me ask one more question, and I think you might have been headed that way a little bit in terms of the dominance of the Delta virus or variant. Will that essentially make life a little easier for the vaccine manufacturers in the sense that they can focus, on that? And I guess also maybe, what I was hearing is that it's possible that because of that dominance that it will tend to burn itself out without other competition. So again, to what you were saying earlier, that maybe we're seeing a little bit of the light at the end of the tunnel.
Yeah, so the current mRNA vaccines, and to a lesser extent, some of the other vaccines out there, they're still working very, very well against the Delta variant. So even though it's not quite as well as the previous variants, they're still working extremely well, particularly against hospitalization, death, and the things we really care about here. And so the big question is, for instance, if we were to talk about getting booster shots, a booster shot with the previous vaccine, without even changing the vaccine at all in terms of how it's manufactured or what it's focusing on, would still probably be sufficient to really even boost it against Delta and some of those variants that we're looking at here. With the booster shot, I think that there's some really good arguments of why we should be getting a booster shot over the next 3 weeks to a couple of months. The big reason I think why there's hesitancy to a booster shot right now, you might have heard various reasons, but from my perspective, the big reason is that there are so many unvaccinated people that we really, really need to get vaccinated. And the problem is, if you recall how hard it was to get a vaccine appointment back in February, March of this year, if we start opening up booster shots to people again, then it's going to make the unvaccinated have a hard time getting their first vaccine shots. And that's going to be really problematic. Every person that we get vaccinated who has just for the first time has an enormous impact on two things. One, their risk of hospitalization and bad consequences, but also their risk of spreading the virus to other people. And so we really, really as a country need to prioritize getting the unvaccinated vaccinated. And right now, I didn't show this because I think it's just kind of silly, but the unvaccinated are just kind of a little bit silly right now. When you ask them, so this is, I think, from the Kaiser Foundation again, Why are they not getting vaccinated? 75% of the unvaccinated who are definitely not interested in getting vaccinated believe that the vaccine is a bigger risk than the virus itself. I mean, it's just crazy talk. Here's even crazier talk. This shocked me. I didn't think that this was actually a real thing. This was the Economist with YouGov did a survey. This was back in early mid-July, and they asked what percentage of people who are unvaccinated believe that the vaccines have microchips in them, have sort of microcomputers that will transmit, not just like a microchip like you might microchip a dog, but will actually transmit information to have a battery and have a full computer in there to be able to transmit a person's information or location or something. And over half of people who have chosen not to get vaccinated believe that there's these like microcomputers in the vaccines. Only 1/3 of this population is sure that there's no microcomputers in the vaccines. I mean, this is astonishing to me. And we somehow have to figure out how to address this because this is very problematic.
As we've been saying, there is a wide range of information that is being disseminated, out there. So this is I'm glad you brought up these kinds of things because I know that there have been some threads, and while I guess technically it's a possibility, it's not happening.
And it's so easy to visualize. Definitely, it's a big theme in sci-fi TV shows and movies now, where you can just have a shot and you suddenly can transmit all this information. So it's easy to visualize, but the modern technology is not there. And so just briefly, if there was a vast conspiracy that this were happening, first of all, I would know about it and I would need to be in on the conspiracy. And the fact that I don't know of anything crazy like this happening means that it's very likely to not be happening. But two, if there was a conspiracy, over 2 billion people with a B have already been vaccinated. The amount of organizational competency that would be required and communication and coordination across adversarial companies, adversarial countries, across governments, across the Trump government versus the Biden government, the amount of coordination and collaboration would be insane to even imagine what would be required to pull something like this off. So it's yeah.
Thank you.
So Glenn, maybe you can clear some of this up then, because some of the hesitation from my perspective and others are that the mRNA, because it's so new, it still hasn't been given final approval through the FDA, and it's only through the EUA process, which still gives a higher risk, even though there's data coming directly from the companies that, it is safe. And the other thing is that from a security perspective, I'm thinking, well, an mRNA process gives a mechanical approach to future types of similar infections or possibly delivery for other kind of concerns in the future. So, you're an expert at this. I'd like to hear your opinion on it.
Yeah, absolutely. So first off, mRNA, so that's messenger RNA, is produced by the virus itself. So this COVID-19, the SARS-CoV-2 virus produces mRNA. The difference is that it produces a huge amount of mRNA in any cell it infects, and it infects cells around the body. So that means that if someone is naturally infected with SARS-CoV-2, they are getting huge doses of mRNA in their hearts, in their kidneys, in their liver, in their cardiovascular system. That's why it's throwing all these clots in their nervous system. That's why there's brain fog and all these other things. Virtually every organ system in the body is impacted, even testicles. So then the worry about fertility being impacted. This mRNA is going everywhere. We don't know how long it persists there. There could be some residual where even if a person is no longer sick, it could stay there for a while. We don't know. In contrast, the vaccine itself only has mRNA that only infects one type of cell. and it's a very, very specific, very self-limited, and it does not reproduce outside of that after all. And so it gets eliminated from the body very, very quickly. We understand those dynamics very well. And so if there's any concern at all about mRNA, then the real concern should be focused because the virus is creating all this mRNA. Now, we've studied it, even though it was technically an emergency use authorization that these vaccines were approved in the United States. There have been, I think, already 5 or 6 countries that have approved it under regular authorization now. And hopefully within the next, I think within 3 to 4 weeks, we probably should have the preliminary stuff done, probably maybe a month, where the FDA is hopefully starting to make a decision. I don't know what the rough time frame is on that. But the emergency use authorization data that was submitted by the country. The reality is that epidemiologists around the world have been looking extremely closely at every possible health outcome associated with this. A lot of countries have way better data than we have in the United States. For instance, the United Kingdom, because it's a nationalized health system, they have information on every single person there. And so it's very easy for people who are looking at that data to look at any possible health consequence of people who are vaccinated and then follow them for months versus people who are unvaccinated and then follow them for months. And there is no controversy here. What we know is that epidemiologists, physicians, anyone else who's looking at this, who is any medical expert, the more they understand about the vaccine and the more they understand about the virus, the more likely they are to be vaccinated. If there was any skepticism here about the ones who are the most expert, you would sort of see a curve that was a little bit different, or maybe you'd see a lot of people getting vaccinated, but then the outliers would be the physicians who are the world experts, or the vaccine manufacturers or the world experts. They might see some variation and they wouldn't get vaccinated quite as much. We're not seeing that. It's just the opposite. The more you know about this stuff, the more likely you are to get vaccinated. There's no controversy here among the medical experts here.
Glenn, any notion or commentary at all about what you think will materialize related to going back to school in the fall?
No, I don't have a good, I think that it's going to vary widely around the country. There's not going to be one policy. I think that some kids are already starting to go back to school. I know it's early August, but there's some schools that are already starting to, and so over the next 2, 3, 4 weeks, that's going to be our natural experiment. We're going to see what kinds of spikes we see, what kind of hospitalization spikes we see. And that's going to be the real world evidence that we have. I mentioned a little bit earlier that Delta is more contagious than the previous variants. Previously, for prepubescent kids, they were less. So the magic number is when R equals 1. That's when, on average, one person infects one other person. You have an epidemic when it's above 1, and when it's below 1, it's always self-limiting. Will always just die out on its own. The interesting thing is that among kids, the ACE2 receptor, that's the primary receptor that the SARS-CoV-2 virus needs to attach to in the cells in the human body, that is very, very limited in prepubescent kids. It might have, who knows, it might have even evolved that way to avoid previous COVID epidemics over thousands and thousands of years. It's unclear to me. But what we do know is that among kids, they have very, very little ACE2 receptor, and so they tend to be much, much, much less contagious, which was great news. And that's where all of the empirical basis for us talking about this came from. The problem with the Delta variant is that now that it makes it 2 to 3 times more contagious in general, it might push that threshold in kids and prepubescent kids above the R equals 1 threshold, and might make it so that once one kid gets infected, you might actually have it where more kids get infected. And it's an area of uncertainty right now. The other thing, again, is the severity question. We still don't have good empirical data of what the severity looks like in kids. We know that and by that, let me clarify. By that, what I mean is we don't know if the probability per infection of a severe disease is the same. And all we're seeing is that we have more rolls of the dice because we have a lot more people getting infected, or are kids getting more severe if they are infected? And based on the viral load, you could hypothesize, and it's a reasonable thing to believe that maybe they are more severe relative to the infection. And there is some evidence to support that. But Delta is so new, we just don't really have a lot of evidence right now to really tell us one way or the other. So that's where we're at.
And Glenn, if you had the virus and then you got fully vaccinated, what's your risk level at this point with the Delta variant?
Yeah, it's a very specific question. At that point, the third dose would be sort of like a booster shot. So most likely what it would do is you have the benefit of the vaccines, which are very focused in terms of their response. The additional booster would then make the antibody levels rise again to very high levels. So the risk would be very low, but it's still going to vary by age, by comorbidity and whatnot in terms of risk of hospitalization and whatnot. I think I like this chart here. This was from the Financial Times, looking at the overall risk of vaccine versus not. I think if someone is, and there isn't great data about that very specific question among people who are vaccinated and infected, but you can see that the vaccines, even the mRNA vaccines, have a limited impact. So if someone's 90 years old and is vaccinated, it does reduce their risk dramatically, but it's unclear how much more flexibility they have, how they can drop below that. Just because the older you are, the weaker the immune system is in general. And there's just a theoretical limit on how much further you can, how much more protection you can get from there. So it's probably just a constraint there.
Thank you. Great job today.
Thanks.
Well, I think we've gone over our allotted time, but I think well worthwhile. So unless someone has like an absolute burning question, and I'll pause. Okay. Well, Glenn, we really appreciate you coming back to speak with us today. Super great information. And I think we are all like tremendously better informed than we were an hour ago. So, so thank you very much. And
thank you very much.
Yeah. I think given what you've said, you probably teed yourself up for, maybe in another month or two. So
great.
We might get some of the other Three Musketeers back as well. But I especially wanted to have you, to really focus in on the situation as the Delta virus, has been more and more of a concern. So thank you very much.
I appreciate it.
I guess with that, Mark, I'll hand it back over to you. And if despite what Glenn just said, if you're going to be in the Hamptons or New York City this coming Thursday, come on out, because there will be a number of us, who are gathering, out there. Eddie and I think Eddie's sort of the main driver of that. But a lot going on. Breakfast. There's going to be some lunches that are somewhat ad hoc. And then I think people are going to be gathering up again around 4 in the afternoon, if I have the schedule correct. So come on. All right. Well, I don't know if Mark just dropped or whatever, but have a great rest of the week, everyone.